Hello, I'm Jeremy Fernandez and welcome to our weekly live stream to answer your questions about the COVID-19 pandemic. So as always, please feel free to leave your questions in the comments sections below and we'll get to as many of them as we possibly can. Now, joining us this week is Professor Fiona Russell, who's a Principal Research Fellow in Public Health and Epidemiology at the Murdoch Children's Research Institute. Also joining us is Dr. Brad McKay, who is a family doctor in Sydney and a regular on this program. Welcome to you both.
Thank you.
Thank you, Jeremy.
Let's get straight into it. Professor, I want to begin with the situation in Melbourne. The numbers have obviously been going down this week, and that's been really the sort of trend that we've been looking for so many weeks now. But the numbers are still fairly high. What do you make of the direction the numbers are moving in right now?
Oh, look, I can say, Jeremy, from all Melburnians, well, certainly for me anyway, and for my household, extremely excited to see the numbers going down to below 200 today. So it's absolutely fantastic. It does take time. We appreciate this does take time, you know, in terms of testing, getting all the contacts, getting the results back, and then making sure everybody's isolated. So now, you know, the department sort of caught up with all the testing, and so we would just expect that those numbers to continue to go down over the next few weeks. So, you know, I think we're very pleased to see that decline, and that's all to be expected.
Do you think that complacency is a risk at this stage?
Oh, look, absolutely. I think so. I mean, I think it's very hard for people to sort of maintain these behavioural changes, you know, that have come to our lives. And, you know, these behavioural changes will need to make these changes for a very long time to come. I mean, even if a vaccine does come, and we heard from the Prime Minister sort of this week that they've made struck a deal with AstraZeneca, one of the companies, to get vaccination for all for Australians. We still will need to do all the social distancing and the physical, distancing measures for quite some time yet. So it's extremely important to keep the community on board and to work out strategies and work with the community to figure out how to, you know, to keep people on board.
What do you think is the best way to do that, given that we've seen frustrations erupt in various ways, people jumping borders, breaching their quarantine or isolation measures? I mean, obviously we're losing a number of people outside the rules here. Do you have any thoughts on how to keep that running for a prolonged period of time?
Yeah, so I think, I think it's really important to have behavioural scientists and social scientists sort of involved with the government in being able to target particular groups. In particular, it may be, I mean, young people, I think, can think in particular, who don't get severe disease, although some of them do, but don't get severe disease commonly, but they are a big source of transmission in the community. And to be able to target people who otherwise sort of feel well but may be transmitting the virus, they're a particular group, I think, that requires some research and some work with, social scientists in the area and behavioural scientists to be able to work and figure out the strategies that work best in these particular sort of groups.
Dr. Brad McKay, these particular people, this particular sector of the community, there are a number of people who sort of take matters into their own hands, perhaps don't take the lockdown measures particularly seriously. And that means that we've got this issue of, you know, a high enough number of cases where the source is unknown. And that's perhaps the biggest risk here, isn't it?
Yeah, if we know where people are getting the virus, then we know what to do about it. But if it's unknown, there's major question marks on everything. So we're needing contact tracers to be very vigilant with asking people where they've been. But if we still don't know, that's a major problem. I think a lot of people have been wondering, look, is it spreading through like air conditioning? Is it becoming more airborne than what we realise? Is it being spread from surface to surface a little bit more than what we're thinking? And so we need to broaden our scope and sort of look at all those possibilities so we can put a stop on those too.
And we have received, Dr. Brad, a lot of questions in regard to those sorts of methods of spread. So, as you say, surfaces, aerosol spread, you know, the issue of cold storage even came up because of what happened in Auckland. What's the latest science on how this virus is getting around?
Well, there's been a lot of debate as well about whether coronavirus would be airborne. So we know viruses like measles are highly spreadable. They can stay around just sort of like hovering in a room for a number of hours after somebody's left. So they can be well gone by the time you walk in and breathe in measles. And so we expect something similar is going on, not quite as infective as measles virus, but still a problem. And what we're needing to do is also make sure that our healthcare professionals are properly masked, that we have proper PPE, that we can protect ourselves and not take the virus for granted, not just think that it's going to be on surfaces or within 2 meters of a patient. We could find it at any place in that room if the patient is coughing and is sick with COVID-19.
What has all this been like for you as a treating medical professional who is seeing patients over and over again, day in, day out?
Well, I'm in my general practice clinic in Sydney, so I'm not seeing patients who are COVID-19 positive at this point of time. But it is a worry. Anybody who comes into the room could potentially have it, even if they're not feeling very unwell. So I think there's a lot of anxiety around even doctors in Sydney. But certainly for my colleagues down in Melbourne, it's a lot more anxiety provoking. And a lot of people are taking massive precautions and trying to do their best. But yeah, there's higher stress rates. There are people that aren't coping very well in the health service, and so we're needing to support them as much as we can.
Professor Russell, I assume you have a shared view on this about how the medical system, people who work in the medical sector, are coping with all of this.
Yes, no, absolutely. I mean, it's a huge burden for the medical sector, and they need to be equipped appropriately, as Brad sort of said, with PPE to make sure that they're safe in their environment. It's very stressful, to be working under these conditions, be masked up all day with gown and glove and being hot and having to change repeatedly and doing all these procedures and their normal day-to-day work in this sort of conditions. So, it's a huge strain. And then, the worry, of course, of potentially being infectious, hopefully not, but, going home with that and having loved ones who might be at risk, or grandparents or parents and their family and things. So we really need to take care of our frontline workers. That's absolutely number one, because as we know, there have been a lot of frontline healthcare workers, infected, and we really need to make sure that they are well and truly looked after.
Now, Dr. Brad, I want to move on to the situation in New Zealand, because they've got now over 100 active cases, having had this erupt very, very quickly. And it's still a mystery where this virus came from. What's the latest thinking about how this could have gotten into Auckland after 100 days of New Zealand being COVID-free?
It is still a mystery. Originally, they were thinking there was a break in quarantine, but when they looked at the phylogenetics, so looking at the source of what the virus looks like and how many mutations it's gone through, they found that it was likely to be more of a source from Australasia rather than coming in from any other part of the world. So they're also thinking maybe cold storage, but I understand that has been excluded at this point of time. And I think we're still waiting for some of the information to come out around the genetics of coronavirus at the moment, to see if it's more likely to have come from Australia and shipped over in freight, or if it is more likely to come locally in Auckland. So I'm unsure what the latest on that is.
Well, I think, as you say, it is still a mystery. Professor Russell, any thoughts on where this might have come from, given that this is a sort of situation that Australia and any country certainly hopes to avoid in the future?
Yes, absolutely. It's extremely concerning for the globe, and so we really need to find out very quickly. Of course, as Brad sort of mentioned, the New Zealand government is doing all the genomics on that to try and understand the source. So looking at the genomics might be able to help us understand where the source is from. And so, as I understand as well, we're still waiting for that information, but that'll help be very greatly well received, and we'll be able to understand it. But huge concern for the global community.
Professor Russell, the Prime Minister was speaking this afternoon about the issue of the economy, about aged care, about the borders being closed. We received this question from one of our viewers. The issue of hotel quarantine is critical right now. Is the use of hotels appropriate, or should governments be resourcing purpose-built quarantine stations like they do in China? Do you have any thoughts on that?
Yes, I think that would be, obviously that's a big big deal for the government to sort of then ship people out into quarantine stations. I mean, that was done many years ago, of course. We've got down in Sydney, the quarantine station at North Head, the old quarantine station, and down in Port Nepean, sort of down in the Port Phillip Bay, there's also the old quarantine station. So certainly that was the strategy, and very effective strategy, many years ago. But I think we can also, give people responsibility. It's education that's extremely important, explaining to people as to what how important it is to sort of isolate, wash hands, keep away from everyone, not to, to be staying in their hotel rooms, etc. So I think if appropriately resourced and educated, using hotels should be sufficient.
Dr. Brad, another question we received. Some people are not staying in quarantine when they should be. Do we know whether they're responsible for this continuing community spread?
So around Australia, are you saying?
Yeah.
So I think a lot of people, when they're tested positive for coronavirus, they're sort of asked to stay at home unless they're really sick and they're in hospital. And we do have this trust policy in Australia. We do expect people to do the right thing. But we see overseas that people don't trust their own citizens. We have seen people on house arrest with ankle bracelets. We've had people locked in their own houses and the doors screwed on. There's all these reports that do come from places around the world. So I think we'd be very reluctant to do that in Australia. And I think a kind phone call is what the police have been doing around Melbourne. And I think we're trying to use gentle encouragement by authorities checking up on people and just reminding them of the importance that they do need to stay at home if they've been asked to.
Speaking of gentle encouragement, someone wrote to us asking if you have any tips on how to tell someone to use a face mask. Obviously, it's not compulsory around Australia right now, just like it's not compulsory to download the COVID Safe app, but it's being strongly encouraged in certain sectors of the community. And sometimes it's a very difficult conversation to have with someone who might walk into your business or whom you might be sitting next to at the bus stop or, something like that. Do you have any tips on how to approach that delicately without starting a conflict?
So, me or Fiona?
No, go ahead, Brad.
I think from my perspective, I do have some patients that are given face masks when they're in the waiting room. And then when they come into the clinic with me, we're in a small room. There may not be the best ventilation. And they'll often whip off the mask and say, I don't really need to use this, do I? So it's really important for me as a GP to explain to my patients that it is important and that they might be feeling well but could still transmit the virus to me. I could be feeling well and not know that I have it too. So it's important for us both to be wearing the masks, particularly at that close proximity. I think some people just don't think that the virus exists as well, which is a little bit weird to me. And certainly I'd be encouraging those people who may have family or friends with that mindset that you could always say to them, well, I believe that it is real. A lot of other people do, and I'd like you to respect my wishes. And please put on a mask when you're in my vicinity, just out of respect for me.
Professor Russell, this issue of masks is one that Melburnians have had to come to terms with in varying degrees because of the scale of the outbreak there. What are your tips on how to encourage that sort of take-up, particularly in the critical situation that Melbourne has been in?
Well, actually, Melbourne is pretty much mandatory. Now, we if we go outside, we need to wear a mask. So, initially when I went out down my street and saw people, at the beginning, there weren't many people wearing masks, and particularly in shopkeepers. And I actually went to up to the shopkeepers and said, oh, look, it'd be really good, if you were able to wear a mask. I actually work in the healthcare sector and, we're really worried and we really need protection too. And we don't want our healthcare system overwhelmed. So, it'd be so wonderful if everybody all started wearing masks to sort of protect us as well. So I use that tactic, but obviously not everyone's a health professional, and so that's a difficult conversation. But I mean, the other option obviously also too is if you're outside is just to move away from the person, and so if you are at risk, but without getting into obviously a heated conversation at all.
We received a question that I'm so glad somebody asked about hay fever symptoms at this time of year. Dr. McKay, we are seeing certain people get hay fever symptoms that overlap a bit with what you might get if you get COVID. And so someone asked us, do I need to get tested every time I get the sniffles? And how do I tell the difference between hay fever and whether I might have COVID-19?
It's a really good question, and as we're about to head into hay fever season, that's going to be great for everybody in Australia. I think if you've got typical symptoms where you get a bit of a runny nose and some itchy eyes whenever you're encountering dust, and like you've already had a coronavirus test and it's been negative, and you're just getting the same sort of hay fever symptoms, then I don't think that you should really necessarily need to go and have a coronavirus test every day. But if you're noticing something different, if there's something a little bit odd or unusual, if you're coughing more, if you're getting a rash, even if you're getting diarrhea, if there's something else more weird, then do think about getting a coronavirus test. But also from a GP perspective, please get your hay fever fixed. Go and see your GP and have a chat with them about it. There's a whole lot of treatments that can actually sort that out for you, so you're not being worried unnecessarily.
All right, we are getting a ton of questions about a vaccine. You would think that a vaccine was just around the corner, which of course, Professor Russell, it isn't. We got this really good question about, the fact that at the start of this pandemic, we were being told that, a vaccine of this sort has never been created before. And now we're talking about, a vaccine possibly being rolled out in the next maybe year or so. How much trust should we have in a vaccine that's been created so quickly?
Yeah, fantastic question, Jeremy. So, it normally takes up to 10 years, to produce a vaccine from the animal studies right through to getting it out there. At least it takes 10 years or so. And so this, as we know, is absolutely unprecedented in terms of the time and the turnaround. That's not to say that the trials have cut corners at all. And so the preclinical studies, which are the animal studies, have been done, and while they're being written up, the human trials have started, and the human trials are very small studies, usually about 30 people, to have a look at dosage, have a look at safety, have a little bit of look at the immunology, and then once that's passed, it rapidly goes into phase 2 and also then a phase 3 looking at efficacy. So it is certainly very rapid development, but all resources have been thrown into this. So normally there's sort of a delay, and then you have to get funding, and then things don't work, and then you go on to the next stage. So there's a whole, circuitous course. But yes, I mean, the thing certainly from the AstraZeneca vaccine, the one that the Australian government has signed up to, that has been announced this week, is certainly looking very promising. But, we do need to be very cautious as well. We don't know whether it works yet. It's showing very promising signs in terms of the immunology. It's producing the antibodies that we like to see. But again, we don't know whether those antibodies are actually effective and prevent us from getting the disease. It has been shown in the monkey studies, so the non-human primate studies, that it does prevent pneumonia and viral shedding in those, those monkey sort of studies, which is very promising and certainly gives us great hope. But we still don't know whether the vaccine is safe, or any of the vaccines are safe. So far, there's about 500 or so people that have been tested with the vaccine. There's no safety signals as yet, but it does need a lot larger sample size to be able to look at the safety. And even after, they're out in the population, those very rare side effects need to be closely, monitored in large populations once they are released into the population. So we are, it's looking very hopeful. But it is certainly a very, we've still got a long road to sort of go.
Dr. Brad McKay, I know you will be encountering this sort of suspicion and concern about the efficacy of a vaccine whenever it's released. How do you counter that eventually when it does become available?
Well, I think a lot of people are anti the vaccine before it's even been invented and rolled out. So we're still looking for the safety and efficacy, making sure that we can give it to people. So once those results are out, I think we'll hopefully be very reassured with that. Time will tell. But I think it's also having those conversations with people now and looking at getting back to normality. And I think if we can only really get Australia and the rest of the world back to a state where we're used to enjoy going out and catching up with friends and not worrying about transmitting a deadly virus to somebody. The only way of really doing that is by having a vaccination and by protecting ourselves and other people around us. So I think it's worthwhile having those conversations early and having them now, but certainly it will be a long sort of discussion point for the population and a lot of science to make sure that we're able to trust this as well.
Awara sent this question on Facebook, Dr. McKay. Is the vaccine likely to be a one-off sort of situation or a yearly, like a flu shot is?
That's a very good question. At the moment, they're looking at giving one shot and then it's followed by a booster shot a number of weeks later. But we really don't know how long that immune reaction is going to last, or even if it's going to protect people from coronavirus in the real world. So this is why we're in phase 3 trials with the Oxford University vaccine at the moment. So one of the thoughts is that it could wane with immunity, so we may need to get a shot every year, but we really don't know. Hopefully the response is good and strong and stable for a long time.
Professor Russell, this question we received: why won't the vaccine be mandatory?
Oh, that's a good question, Jeremy. I think, I think it's extremely important that the vaccine isn't mandatory. I mean, I don't think any of us like being told, what to do. We like to make our own decisions, and we like to make our own decisions after we, so we can make an informed choice. I mean, if I knew that the vaccine was safe and effective, I'd be the first sort of lining up there because I would want to have the vaccine. And same with my household, I'd be encouraging all, my household to get the vaccine too. But it's extremely important because there are people, we don't know yet whether it's safe. People do have questions, and very rightly so, and questioning the whole process, of course. And so all those conversations need to be had. We need to explain to people how vaccines are tested. The whole process is about safety and what the side effects of the vaccines are, and also whether they actually work. I know we don't even know those, the answers to those questions as yet. So we certainly can't be making a vaccine, mandatory. I mean, a lot of people do have sort of questions, but with information and with the right information, from their trusted health provider, do then go on to, want to be, receive the vaccine. But it's extremely important that we put all those educational messages out there once we know more about the vaccine and what it can do and how effective it actually is.
Dr. McKay, if you take the lack of mandatory vaccination, the suspicion that surrounds it, and you apply that to a population, is there a threshold at which point a vaccine just wouldn't be effective, a vaccination program wouldn't be effective because there's not enough of a take-up rate? How do we know, what is the threshold at which a vaccine will be effective?
That is a big question. I think we're still waiting to see what the answers will be. But traditionally, we do want more than 95% of the population being vaccinated. So this is what we have as a bit of a standard aim or a goal across the board with public health to make sure that enough people are vaccinated so it doesn't keep on spreading around. So if we're only getting, for example, if we're only getting 60% of people vaccinated, and then say the vaccine is only 50% effective for people, so we just don't know those figures yet. But that could mean that only 30% of the population is protected. And that means there's really no change in what we're doing now. We have to keep on doing what we're doing. So hopefully it will be very, very effective. And hopefully we'll have a lot more than 60% being vaccinated.
Professor Russell, we received this question from a viewer during the week asking about the Oxford vaccine that's being developed. Saying it's a live virus. Some of us that are on immunosuppressive therapy are not able to have live vaccines. I'm not quite sure I understand what that means. Can you just take us through the nature of that vaccine that's being developed at Oxford and what it means for people who do have suppressed immune systems?
Yeah, sure. So it's based on a virus, a common cold virus, really, that causes cold in monkey or chimpanzees, actually, and it's called adenovirus. And what the developers have done is basically stripped out all the genetic code, or most of the genetic code of the virus, so that it doesn't create an infection. And so what they have done then is then inserted genetic components of the SARS-CoV-2 virus so that it's able to then enter the human cell and then stimulate the immune system in a way that produces protective antibodies. So it's basically like injecting a fake infection, a fake SARS-CoV-2. So it produces the immune response, but it doesn't create the disease.
And does that mean it doesn't work on people who have a suppressed immune system?
Oh, well, it's actually not a live virus. Yeah, sorry, I didn't answer your question very well. So it's actually not a live virus as such. So it won't, so it hasn't been tested yet on people, older people with, immunosuppressive conditions, but it will be later on. And so, but it wouldn't be a contraindication for people like immunosuppressive because it's not actually a live virus.
Dr. McKay, someone's asked us about whether such vaccines, given the scale of these outbreaks, particularly in other parts of the world, whether it's ethically reasonable to test vaccines on the most vulnerable in the community. What are your thoughts on that?
Well, at the moment with the Oxford University vaccine that we've been talking about today, they've mainly been using it on healthy people between the ages of 18 and 55. And this is all in like phase 1 and 2 trials. So looking at phase 3, the next stage, they are looking at different age groups. There's a group of about 50 people in an African country. I'm forgetting which country, but there's about 50 people who have HIV. And so they're looking at giving the vaccine to those people and seeing if it's going to be working as well. So this will be part of a phase 3 trial. And this is sort of the crucial area. If we know that it works really well in healthy people and they survive coronavirus, who cares? Like they would survive anyway. But what we are wanting to do is look at the more vulnerable people, the people who have multiple comorbidities, multiple health problems, and the elderly, and make sure that it's going to be working for them. So this is an integral part of looking at the next phase and making sure that it is safe and effective for the people who are vulnerable in our communities.
Dr. McKay, talk us through some of the supportive treatments that are being used for people who do test positive for the COVID virus to reduce their risk of becoming seriously unwell. Obviously, there's no vaccine at the moment, but there's a range of treatments that are available to help people not get as sick as they otherwise might.
Yeah, so there's quite a few things that are in transit at the moment, so to speak. Some of the things that we do know that will help in intensive care are dexamethasone. So this is a steroid that can dull down the immune system and stop it from being exponentially horrible for people. We also have remdesivir. So this is an antiviral medication, which is modest in its results, but can also decrease some of the time that people spend in hospitals. There are other weird and wacky things that are on the way. So there has been some talk this week about pineapples and taking a protein from the stem of a pineapple and possibly using that as a nasal spray to line the inside of your nasal passages where it seems to, this is in a lab setting, of course, melt away the spike proteins, the glycoproteins that are on the outside part of the virus. So we're still waiting for some studies to come back to see if this is going to be another way that we can prevent coronavirus from getting into people's bodies in the first place.
All right, Professor Russell, let's move on from the issue of vaccines to one of the interstate borders. Obviously, in different parts of the country, different people are calling for the borders to be reopened. How strong, in your view, is the case to keep interstate borders closed on medical grounds?
Yes, well, certainly, for Victoria and New South Wales that have got, active community transmission, it is important. I mean, I think, if I was the Western Australian Premier, I don't think I'd be very keen on opening my borders to anyone at the moment, just because, I wouldn't want, to travellers to come in and breach quarantine potentially and start spreading it in my community and then having to go into lockdown like Victoria and, Melbourne's had to go through. So I think, certainly at this stage with what's going on in Victoria and New South Wales, I can especially understand the states because the impact on the economy, by lockdown and the upset with schools and all the social impact, of people being stuck at home and, the mental health issues are enormous. And so I can completely understand the premiers in the other states. I think if I was in their position, I would definitely be doing the same thing.
What about travel, in your view, between places like Western Australia and the Northern Territory? Does that pose a risk as well? I mean, the WA border is closed to everyone at the moment. Would you say that travel between places where there is no community transmission is a lot lower?
Yes, I mean, there's certainly, it appears that that could be possible, that everywhere except New South Wales and Victoria could open up. But I guess there's just, everyone's seen what's happened in Victoria and Melbourne, and nobody really wants to go through this. We don't want businesses to go bust. People are just very scared and I think very cautious. And I can completely understand that, what the premiers are doing.
Dr. McKay, I'm looking at the live stream right now and I'm seeing a lot of comments about pineapple. A lot of people finding that quite amusing, I think. Now, until there is a vaccine, Dr. Brad McKay, how do we manage COVID-19 and the economy in the long term? I mean, someone wrote into us and asking, are we going to overreact every time there's an outbreak of some sort in the future? What does the future look like when we talk about living with the virus?
Yeah, so this is a really hard conversation that we didn't really want to have early on, where we were seeing, if there is an outbreak, then we do need to clamp down on it, and we will be going through sort of like boom and bust with our approach over time. This is the likelihood, unless we have a vaccine. So I think looking ahead and what this means for people, often it will mean sort of changing jobs and finding a different way to do what you've been doing. We're seeing overseas a lot of like outdoor restaurants, outdoor cafes, outdoor markets, because we know that the transmission rates in those open spaces are much less compared to being in an enclosed space. We do need to change how we're living our lives. And I think the other aspect as well is finding where the outbreaks are and clamping down on those areas pretty quickly. So sometimes we will be talking about ring fencing. So just picking off suburbs where there are outbreaks and making sure that those few people are sort of staying in their homes while everybody else goes around their daily life. And we may need to keep on doing this and get better and better at focusing our efforts into different areas of the community.
Professor Russell, can I get your view on that, particularly, from the perspective of a Melburnian, where we've gone from this idea of pursuing suppression to now thinking elimination might be quite a good idea, but perhaps a bit unrealistic?
Yes, no, certainly from my perspective, I don't want to go through this again. So I would be happy to, keep getting things down to and go for the elimination strategy. That's for sure. But I can understand other people, may not want that. But the important thing is, as Brad has sort of said, is just, now we had a bit of a raging bushfire, but now we've got the fire under control, and then it'll come back to spot fires. And the most important thing, and hopefully be extinguished, in terms of elimination. However, that may not happen, and it probably may not, but there'll be spot fires that will pop up. But the most important thing is putting out those spot fires, and it's up to each of us as an individual to be, going forward and getting testing, maintaining the social distancing, the hand washing, and then if we are being tested, to stay at home until we get the test results, and then, the contacts likewise. So it's really up to all of us as individuals, because we as individuals, create this, but we can also stop this. We've all got our own individual, it's essentially up to us.
I want to just clarify a point that I'm seeing coming up over and over again on the comment sections on the live stream. There is no vaccine yet. A vaccine hasn't been created. We're not even sure how far away it is. So we don't know the company that owns the patent. We don't know how effective it's going to be. This is very much a case of wait and see. Stay tuned, I guess, is the best advice I can offer. Dr. Brad McKay, we got a question from a number of people about the education system. I was having this chat with someone the other day who said, jokingly, that her kids are not going to be any smarter at the end of this academic year than they were last year. Someone also wrote to us saying she's got two daughters, they're in pre-clinical years at university, and their courses had to be dramatically changed. What is all this going to do for the educational quality of our university courses, the quality of doctors that are coming out of as graduates?
Well, I have a number of medical students who I look after. I'm their GP, and they're sitting at home and they're trying to study via Zoom. They're having lots of lessons online, and it's really hard to examine somebody's abdomen if you're on the other side of a computer screen. So I think a lot of the education at this point of time is trying to adapt and trying to do the best that we can. And as time goes on, they'll be going back into the hospitals and they'll be putting hands on people's bellies and they'll be able to have that practical experience. So I think part of it is adjusting. Teachers all around Australia and all around the world are doing on.
Okay, we appear to have lost Dr. Brad just for a moment there. The stream, as you would know, does freeze up every once in a while. But let's go to Professor Fiona Russell. I think you're still there, aren't you?
I am, yes.
Terrific. Now, can I just get your view on this about the impact on education, not just for school students, but for university students who are trying to adjust as best they can at this time?
Oh, look, it's very hard. I mean, it's extremely hard. I sort of manage the PhD student program in our area, and it's incredibly hard, particularly for the PhD students who have got young children, who have got young, and homeschooling as well in particular. So it's extremely tough time for students of whether it's primary, secondary or tertiary students. And we're all going through a period of adaptation to do as much as we can by Zoom. But, people are resilient, too, and people can sort of catch up enormously. And my kids, I've got 2 teenagers at home, and they actually prefer sort of schooling at home. I mean, certainly not all families would be like that, but that's their preference is to do online schooling. But in terms of the medical students too, their whole curriculum where I am at the university has all been changed, and so that their clinical placements are deferred till next year mostly, and then they're doing their research now, and so they're doing their research now and doing a lot of stuff online. So it will come. I mean, having hands-on placement again is come. It's just a matter of being patient, adapting, and but it's extremely challenging. It's been a huge upheaval for the education sector, and I just take my hat off to everybody in the education sector. Have done an enormous area of adaptation on this.
Professor, someone wrote to us saying that his sister was given a self-administered COVID test. She did the test on herself. The results came back negative. Now, how widespread are these self-testing kits, and how well do they work?
Yes, well, that's a good question. I'm not aware of what the self-testing kit that is available over the counter, but I certainly wouldn't trust anything. It's important that the health system knows and you account it for a start, that you're not testing yourself. So if you do have symptoms, it's best to go to what your government or your state government is recommending for a provider rather than doing something over the counter or getting something from the chemist, which I wasn't even aware was even available. And testing kits can vary widely, in terms of how good they are and how valuable and how reliable they are. So I'd really, probably strongly discourage people from doing that, and just, it is inconvenient, probably going out and, and lining up and or in a drive-through and perhaps having to wait. But the reliability of the test kit, whereas the ones that, this one may not be even very useful or giving you a reliable, result.
Professor, what are the ramifications of the virus continuing to mutate?
Yes, well, it already has mutated. And so just slightly. So and we don't know what will happen with the vaccine. So at the moment, it's sort of nothing too alarming, but the potential is certainly there. We know with influenza virus that mutates every year, and so that's why the vaccine needs to be changed every year and to be redesigned every year for influenza to be able to keep up with the mutation of that particular virus. Again, this is a new virus. We don't know what it will do. We don't know what it will do after vaccination, but we're doing a whole lot of genomic testing. So all, for example, everybody that gets tested in Victoria, all of it's sequenced, and we'll have the genomic information on that. And so at the moment, there hasn't been shown too much of a drift, but we need to very much keep an eye on it. And so that's the potential. We need to keep monitoring that.
We're getting more questions about vaccines, Professor. Someone asking, what if the AstraZeneca vaccine, that deal has been stitched up with, is not the one that works, but something else does? I mean, how do we guarantee access for Australians and indeed people in other countries too, to make sure that some sort of broader conflict doesn't break out because there are the haves and the have-nots?
Yeah, no, absolutely. Extremely important question about equity in terms of access, in the globe. So Australia, in principle, has signed up to there's a global vaccine facility called COVAX, which is a global effort to make sure that, particularly the poorer countries have access to the whole world. Everybody's got sort of access to this vaccine at an affordable price. And there is wonderful news that for particularly the poorest countries and our nearest neighbours, in fact, all the Pacific Island countries and Indonesia and Papua New Guinea, Philippines, etc. in our region will be able to get a vaccine once it's available for just $5 a dose, which is absolutely sort of fantastic. And there is a risk that this vaccine doesn't work, the one that the Oxford vaccine. I understand that the deal that's been made with AstraZeneca is that the government will only buy the vaccine if it actually has been shown to be effective. So we still have to wait for the phase 3 trials. But the good news is that there are 160 other vaccine candidates out there, and at least 30 or so of them are in human trials. So, which is the best thing. We need to have a whole range of manufacturers of this vaccine, because some of them might prevent disease, but what we also want is that to prevent transmission, which is extremely important. We need to turn off the tap. So not only do we want, people to not get, die or, end up with, in intensive care, we also want to just stop all this transmission in the community so we all get our lives back. And so we want a vaccine to be able to do both of that. So some of the vaccines might only prevent disease and others might prevent transmission and disease. And so, the time will tell us which one, and we may need a combination of different vaccines, for different age groups. And so it's a very, very much a big moving feast, and, it's watch this space. And so it's just a matter of keep communicating to the community, where things are up to, the new vaccines that are coming. And, but, it's fantastic that there will be hopefully plenty in the market, and hopefully for everybody.
Professor Fiona Russell, it's been terrific to have you on this live stream for this Q&A. Thank you so much for joining us, and also apologies to our viewers. We couldn't get Dr. Brad back on the line for some reason. We'll go away and try to work out what exactly happened there, but our thanks to Dr. Brad too, and to you, our viewers, for sending in those excellent questions. We'll be back again next week with more of the same, so join us then. Bye for now.